first, Phil. My name is Katie Meyer, and I serve as the Senior Director of Content Creation at APHA, and I'm very excited to be your host. Today, we're going to discuss a couple of recent new drug approvals that have likely hit your newsfeed. The first, aztreonam-avibactam, or Amblivia, the first and only monobactam beta-lactamase inhibitor approved to treat complicated intra-abdominal infections. The second, suzetrigine or Journavax, a first-in-class non-opioid analgesic approved to treat moderate to severe acute pain in adults. We wanted to be sure to keep you apprised of information about these two new agents that you'll likely begin to see in practice soon. In part 2, I have invited my mentor and dear friend, Remington Medal Award winner and the go-to resource for all things new drugs, Dr. Dan Hussar, to provide us with information about his approach to evaluating new drug approvals. Before we dive in, I'd like to introduce my guests today, Yara and Michelle. Yara and Michelle, why don't you introduce yourself?
Hello, everyone. My name is Yara Alsher, and I'm the current executive fellow here at APHA. I'm really excited to be here.
Hello, my name is Michelle Dano, and I'm the Associate Director of Content Creation at APHA. It's great to be here today.
Welcome, Yara and Michelle. I'm so excited to have you both here today. So let's dive in with our first agent. We'll start with aztreonam and avibactam. Michelle, can you tell listeners a little bit about Amblivio's path to approval and include relevant information about relevant clinical studies?
I sure can. Amblivio received FDA's Qualified Infectious Disease Product, or QIDP, and Fast Track designation in 2019. While you've likely heard of the Fast Track designation, which accelerates drug development for serious conditions with limited treatment options, QIDP may be less familiar to you. The QIDP designation provides incentives for development of new antibiotics, including priority review through Fast Track designation and an additional 5 years of exclusivity in addition to the typical 5 years that all new chemical entities receive. As a reminder, this means the FDA cannot approve generic versions of this drug during this 10-year exclusivity period. Amblivio is FDA approved for patients 18 years and older needing treatment of complicated intra-abdominal infections who have limited or no alternative options. Susceptible gram-negative microorganisms include Escherichia coli, Klebsiella pneumoniae, Klebsiella oxytoca, Enterobacter cloacae complex, Citrobacter fruendii complex, and Serratia marcescens. Amblivio must be given in combination with metronidazole, as this is how it was studied in the initial clinical study. Speaking of that initial clinical study, the study that led to Amblivio's approval was recently published in the Lancet of Infectious Diseases and is called REVISIT. REVISIT was a prospective, multinational, phase 3, open-label, randomized trial where hospitalized patients with a complicated intra-abdominal infection were randomly allocated to either aztreonam-avibactam with metronidazole or meropenem with or without colistin for 5 to 14 days. Medication use in patients with pneumonia, either HAP or VAP, was also studied, but Amblivio is not approved for that indication. The primary endpoint was clinical cure within 3 days before or after day 28. A total of 422 patients were enrolled and randomly allocated, with 271 having at least one gram-negative pathogen identified at baseline, most commonly Enterobacterales in 252 patients. With patients with complicated intra-abdominal infections, the adjudicated clinical cure rate was 76.4% for the aztreonam-avibactam group and 74% for the meropenem group. Aztreonam-avibactam was generally well tolerated. Adverse reactions associated with use of the medication were minor and consistent with aztreonam monotherapy.
Thanks, Michelle. On the topic of adverse effects, can you tell listeners a little bit about what to be on the lookout for and discuss dosing recommendations for the new agent as well?
Absolutely. As I mentioned above, most adverse reactions in Amblivio's clinical study aligned with those expected from aztreonam monotherapy, as reflected in the labeling warnings and precautions. Risk of hypersensitivity reactions, including rash, flushing, and bronchospasm, are noted. Additionally, toxic epidermal necrolysis, also known as TEN, has occurred with aztreonam in at-risk patients and is therefore listed. Elevated hepatic transaminases and Clostridioides difficile associated diarrhea are notable concerns. If either occurs, discontinuation of the agent and appropriate monitoring or treatment may be necessary. The label advises only prescribing Emblavio for infections that are proven or strongly suspected to be caused by susceptible bacteria to minimize drug resistance. Minor adverse reactions that occurred in over 5% of Emblavio-treated patients included anemia, diarrhea, hypokalemia, and pyrexia. Emblavio should be administered with intravenous infusion over 3 hours. For adults with an estimated creatinine clearance greater than 50 milliliters per minute, the recommended dosage is 2.67 grams aztreonam for 0.67 grams avibactam loading dose, followed by 2 grams aztreonam with zero point 0.5 grams avibactam every 6 hours for 5 to 14 days. Dose adjustments are required if creatinine clearance is below 50 milliliters per minute, as outlined in the prescribing information. For patients on hemodialysis, an adjusted dose is recommended and administered after hemodialysis on dialysis days.
Thanks, Michelle, for reviewing this new medication. Overall, it sounds like it will be a useful option for patients with gram-negative multi-drug resistant intra-abdominal infections. It will be interesting to see if the medication's indications expand with time. All right, let's shift gears and switch over to our next medication, suzetrigine or Jornavax. Yara, can you tell listeners a little bit about Jornavax's path to approval, including relevant clinical studies?
Sure, I'm excited to talk about Jornavax, also known as suzetrigine, a novel class of pain management medication for treating moderate to severe acute pain in adults. Jornavax is a sodium channel blocker that reduces pain by targeting pain signaling pathways in the peripheral nervous system before the signals reach the brain. Jornavax was granted FDA approval on January 30th, 2025, along with a breakthrough therapy, fast track, and priority review designations. This approval is a huge milestone in advancing non-opioid pain treatment options, something we as pharmacists have been anticipating for a while given the urgent need for effective non-opioid alternatives. Its efficacy and safety were evaluated through two phase 2 randomized double-blind placebo-controlled clinical trials involving patients with acute pain after abdominoplasty or bunionectomy. In the abdominoplasty trial, participants received either high-dose Jornavax, which consists of 100 milligrams loading dose followed by a 50 milligram maintenance dose every 12 hours, or mid-dose Jornavax, consisted of 60 milligrams loading dose followed by 30 milligrams maintenance dose every 12 hours, or a 5 milligrams of hydrocodone bitartrate and 325 milligrams of acetaminophen every 6 hours, or placebo every 6 hours. A total of 303 participants were involved with an 81.5% completion rate. In the bunionectomy trial, participants received similar to what was received in the abdominoplasty trial, but with the addition of a low-dose Jornavax, and this consists of 20 milligram loading dose followed by a 10 milligram maintenance dose every 12 hours. In this trial, a total of 274 participants were involved with a 90.1% completion rate. Some key points include high-dose Jornavax showed a mean pain reduction difference of 37.8 compared to placebo in the abdominoplasty trial and 36.8 in the bunionectomy trial over 48 hours. For the time-weighted sum of the pain intensity difference over the 24 hours, the difference was 19.6 in the abdominoplasty and 13.7 in the bunionectomy compared to placebo. Lower doses of Jornavax, hydrocodone, acetaminophen, and placebo showed similar pain relief.
Thanks, Yara. What are some key counseling points that pharmacists should provide to patients about this new medication?
Of course, so Jornavax comes in a 50 milligram tablets and is indicated for the treatment of moderate to severe acute pain in adults. The recommended starting dose is 100 milligrams by mouth on an empty stomach at least 1 hour before or 2 hours after food to avoid delays in the onset of action. 12 hours after the initial dose, take 50 milligrams by mouth every 12 hours. These doses can be taken with or without food. The most frequently reported side effects are pruritus, muscle spasms, increased creatinine phosphokinase, also known as CPK, and or rash. It is crucial to educate patients to stay hydrated by drinking plenty of water and to immediately report any symptoms of muscle pain, weakness, or dark urine. Also avoid use in patients with severe hepatic impairment. Journavex is both a CYP3A4 inducer and substrate, meaning that concomitant use with strong CYP3A4 inhibitors is contraindicated and should be used with caution in drugs with narrow therapeutic index like tacrolimus and cyclosporin. Common strong CYP3A4 inhibitors to avoid include grapefruit, antifungals like ketoconazole, etraconazole, voriconazole, macrolides, antibiotics like erythromycin, protease inhibitors such as ritonavir, lopinavir, atazanavir, and calcium channel blockers like veramipil and daltiazem. For patients using hormonal contraceptives containing progestins other than levonorgestrel and norethindrone, should use additional non-hormonal contraceptives such as condoms or switch to alternative contraceptives. Options include combined oral contraceptives containing ethinyl estradiol and either levonorgestrel or norethindrone or an intrauterine system (IUS). Please note that these measures should be continued during treatment with Journavex and for 28 days after discontinuation. There are no established safety and efficacy data for the use of Journavex during pregnancy to evaluate the risk of birth defects, miscarriages, or other adverse maternal or fetal outcomes. Additionally, there is no safety and efficacy data for pediatric use.
Thank you so much, Yara, for that valuable information. This new medication sounds like it could certainly be a big one in terms of the pain landscape and kind of change the way we're looking at treatment of pain. So it'll be interesting to see kind of how clinical recommendations pan out. All right, y'all. To summarize major takeaways from our time here today, aztreonam-avibactam was the first monobactam beta-lactamase inhibitor approved in patients 18 years and older for the management of complicated intra-abdominal infections who have limited or no alternative options. The medication should be used judiciously to avoid antimicrobial resistance, and when it's used, a dose adjustment is required for patients with an estimated creatinine clearance of less than 50 mL per minute. Adverse reactions found in the clinical study that was the foundation for its approval were similar to those of aztreonam and included anemia, diarrhea, hypokalemia, and pyrexia, and more severely, elevation in hepatic transaminases, C. diff diarrhea, TENS, and hypersensitivity. Suzetrigine is a first-in-class non-opioid analgesic approved to treat moderate to severe acute pain in adults. As a sodium channel blocker, suzetrigine works by targeting pain signaling pathways in the peripheral nervous system before the signals reach the brain. The drug is available in 50 milligram tablets. Common side effects include itching, muscle spasms, increased CPK, and rash. It's important for patients to stay hydrated and report any symptoms like muscle pain, weakness, or dark urine promptly. Because suzetrigine is both a CYP3 inducer and substrate, cannot be used with strong CYP3 inhibitors or inducers. Additionally, women using hormonal contraception should use non-hormonal backup methods or switch to alternatives like combined oral contraceptives or an intrauterine system during treatment and for 28 days after stopping the medication. It is also not recommended for use during pregnancy or in children due to lack of safety data. All right, that's all the time we have here for today. If you enjoyed this month's update on new drugs, be sure to check out our March Pharmacy Today CPE article. Next week, I have the honor of recording episode 2 with my mentor and legend in new drugs, Dr. Dan Hussar. We'll be recording live from APHA 2025, and Dr. Hussar will discuss best practices for pharmacists to consider when evaluating a new drug based on his years of experience doing so himself. Last but not least, don't forget to head over to the Learning Library at learn.pharmacist.com to earn your CE for this month's podcast. We'd love to hear your feedback. Take care.